I'm going to introduce the many benefits of the diode lasers for the modern dental hygiene practice and go over some of the compelling science and research to support the use of lasers for non-surgical periodontal therapy. I'd like to introduce Beth Parks, our presenter. She is an engaging presenter who's been a registered dental hygienist for 16 years. She has worked in general and independent practice, mobile dental hygiene, orthodontics, and periodontics. She is proudly the new Vice President of RDHU in Burlington, Ontario, the leader of RDHU's Diode Laser Training Center for Canadian Dental Hygienists, and a cast member of the ever-popular CE show, The RDH View. Her vision is to help create leaders in the dental hygiene profession, empowering them with knowledge and skill sets that will set them apart. So I'm going to hand it over to Beth Parks for a wonderful presentation. We'll take Q&A afterwards, and I'll let you know about your CE afterwards. Thank you so much, Beth. Take it away.
Perfect. Thank you so much, Nathan. Well, it's a true honor and a privilege to be here. So thank you, everyone who's taken the time to, spend this evening, early evening or late evening, depending on where you're coming from with me. Because of people like you, I get to talk about things that I'm very, very passionate about. So I really do appreciate your time, and I take that very seriously. So the title of this evening is Shine Bright Like a Diode. So we're going to be talking about diode lasers, and even more specifically, talking about how that translates to the dental hygiene department and how we can use that to advance our periodontal programs. So before we go too far in, I do just want to say a huge thank you to Waterlase, first of all, for having me here and giving me this opportunity, but also just for the support that they've given us in the dental community. Because of them, I really do feel like we have the tools that we need to be able to use lasers both safely and effectively. So for that, I really want to say thank you right off the bat. And as Nathan just graciously explained to you, my name is Beth Parks, and I am in fact the Vice President of RDHU. We're a professional development company, Canada grown, but international in content and delivery. I love what I do. I love working with dental hygienists and just sharing things that I'm passionate about. I get to surround myself with like-minded individuals every day, which is something that I definitely don't take for granted. So I am Canadian. I live in Stratford, Ontario. Most of us in Ontario we just say we're from Toronto, but that is about an hour and a half north of Toronto, home of Justin Bieber. So you are welcome. I'm married, so that's my handsome husband in the center, Andrew, and our two beautiful children, Grace and Cole. And then of course, my puppy Piper. And Nathan told you earlier on that I get to be part of this show called the RDH View. So it's something that we're pretty proud of and we have a lot of fun with, where we get to interview someone from the dental community once a month. Another aspect of what I do at RDHU is I do lead the Canada's Laser Training Center for Dental Hygienists. And that is something, it was a real gift that was given to me. One of my mentors was and is Joanne Jones, and she was the founder of this program. And so when I was asked to take it over, I really did, make it my personal mission to make Joanne and Kathleen Bacrossi proud of me. So that's what I'm trying to do every day. Another aspect of what we do is Dental Hygiene Quarterly, which you may have heard of, and that's our online CE membership. So it's 12 hours of CE every year. So that's a little bit about what I do. Most of what I do has, like many of you, become virtual, which has been a real, started off as something that was a little bit kind of unknown to me and maybe a little bit tedious to transfer everything that used to be hands-on to this virtual format. But we do offer some hands-on events as well. So if you're ever looking at, advancing your profession and wanting something hands-on, I love Canada. And I really do feel it's worth the trip out to Canada. It's a beautiful place. Just a couple of things if you are planning to come up to Canada. We actually have a real hard water problem in Canada. In fact, it's usually frozen.
You can't tell, but I'm laughing.
Thank you. And just another couple of icebreakers. I heard that as a presenter, it's good to start with a few icebreakers. So just a couple of questions here. How do you get 50 Canadians out of a swimming pool? You say Can everyone please get out of the swimming pool? And then they just do. Okay, one more question. How do you get a Canadian to apologize? You stomp on their foot, right? I'm so sorry, eh? All right, well, stop messing a boot and just get right down to it. Because you've decided to be here with me today, I'm going to assume that you did have a chance to see the learning objectives. But let's just take a quick moment and review those before we move forward. And I promise not to use too many bad Canadian jokes as we move through. I can't promise, but I will try my best. So tonight we're going to learn how the soft tissue diode laser can be used as an adjunct to mechanical debridement to obtain and maintain optimal oral health. We're also going to talk about how the specific wavelength of the diode laser is helping to reduce the bacterial load, delay bacterial recolonization, and promote tissue healing. And then thirdly, we're going to talk about how the diode laser can easily and effectively be integrated into the dental hygiene therapy appointment for healthier practices intraorally, systemically, and financially. Now, I would say as a dental hygienist, the intraoral implications and the systemic implications is what gets my heart going, right? Not as much the financial aspect. That's not really what gets me motivated and gets me going. But here's the thing. If talking about the return on investment of lasers can help even one person who's here tonight get a laser into their practice, then I am 100% here for that conversation. So we will briefly touch on that towards the end. But before we go too far, I just want to ask this question to you. So when you hear the word lasers, pay attention to kind of the emotions or the thoughts that are elicited from that. The reason that I ask this is because, many of us who are here are already here because we know what lasers can, or we have an idea of what lasers can do in dental hygiene. But when I graduated back in 2005, and about 2 years later was asked if I wanted to attend a laser certification course, I really wasn't too sure what to expect. And in 2007, laser therapy and laser use in dentistry was by no means new technology. But where I'm from, it really wasn't widely used, especially in dental hygiene. So I remember, being in a people that were raised on either Star Wars or, Austin Powers, the word laser held certain connotations. So I just didn't know how my patients were going to accept this type of treatment. So I took the course and I was all fired up and ready to do this. And I would travel from one operatory to the next, because at the time I was the only dental hygienist who was certified. So I walked into my first room and I could tell the hygienist had sort of, tried to prepare the patient for what I was about to do. I walked in very, timidly and, "Hi, Mr. Smith, I'm Beth." And he stopped me. He goes, "Oh, you're a laser girl." And I went, "I am, that's me." And, I was hooked from there. And I've sort of worn this like a badge of honor since that day. No one else calls me laser girl, but, in my heart, I feel like that's who I am. So I would say this is back in 2007, and I was proven wrong. They weren't fearful about this. In fact, this patient and the other ones that I saw afterwards were excited about it. So I would say even more so now, lasers are everywhere. We don't have to be nervous that our patients are going to be kind of scared about what's going on. In fact, quite the opposite. I feel like we should be, preaching this message and telling everybody and their families that we have lasers. And, I think they're expecting it. I think that they're hearing about their friends or their family members who have had lasers used, and they're wondering, well, does my office offer this top of the line technology? So it's something really exciting and not something that we need to be fearful about talking to our patients about. So when it comes to lasers, really kind of where the work is it's in learning the science and the physics behind lasers. And as you progress in your laser journey and you attend a laser certification course, you're really going to dive deep into that part. And that's where the power comes in. Understanding the physics, understanding how certain parameters around lasers will impact how successful the laser is going to be is where the power comes in. And we're not going to dive too deep into that this evening. I'm just going to give you some laser fast facts that are going to help us just to have a common verbiage as we move through. So the first one here, the primary action of a diode laser is really absorption. and it's absorption in chromophores that that specific laser is attracted to. So when we talk about our diode lasers, they're attracted to melanin, which is that pigmentation, hemoglobin, and then to some degree water. This absorbed laser energy, it penetrates with a mild thermal reaction in target tissue in low settings. And that's really key. In hygiene, we are using sub-surgical settings. Okay, so we're not, causing tissue trauma. We're not slicing through tissue. We're using low-level sub-surgical settings. And if you've attended any laser course, you've probably heard the acronym LASER, which is light amplification by stimulated emission of radiation. And that word radiation is kind of a buzzword, but when it comes to our lasers, that radiation is non-mutagenic and non-ionizing. So it doesn't have that same kind of harmful effect that's attributed to something like an X-ray, right? It doesn't have that accumulative effect in the body. It's not nicking our DNA as it's passing through the tissue. Currently, lasers are being used as a non-invasive and non-toxic alternative to some pharmaceuticals to reduce inflammation, reduce pain, reduce the bacterial load, and delay the recolonization period of keystone pathogens, right? And that's something that we need to celebrate. And that's also something that people are looking for, right? Kind of moving away from heavy pharmaceuticals and looking for other alternatives. When it comes to actually selecting your laser, there are some questions that we should be asking ourselves. The first thing is, what do we want the laser to do? And another way we could say that is, what do we want the tissue, or what tissue absorbs the wavelength of the laser we're looking at? In hygiene, we're looking for something that's going to interact with that soft tissue. And that's why I would say the diode laser is going to be our laser of choice, because we don't want it to interact with hard tissue. Right? Hard tissue lasers are attracted to hydroxyapatite. But for us in dental hygiene, if we were to select that laser, we would increase the risk involved without really increasing the benefits for our patient. So a diode laser is going to be that soft tissue laser of choice for us in dental hygiene. Another thing you want to ask is there evidence-based research denoting its efficacy? And that's something I'm really passionate about. And I have probably maybe 40 studies that I really like. And I promise you, I'm only going to share a few. I've narrowed it down. I picked my top 3, and I will share those with you later on. But that's important, right? We need to have this personal conviction that what we're suggesting to our patients is backed by reputable science. And the Waterlase website is an excellent resource for that as well. So I'll share a couple this evening. If you want more, I would encourage you to check out that Waterlase, the Waterlase resources. Another thing you want to look at is the initial cost in your sundries expenses. So what's the initial cost of your unit, and what's the cost of the replacement tips? Just so you have a good idea of what to expect. Is it user-friendly? So I specifically put a picture here of the Epic H on this slide. And it's because I have to give them credit. They had a group or a panel of dental hygienists who were specifically involved in the production of this unit. How do we want the handle to feel? What do we want the face to look like? Right, so when you are looking for a diode laser, look at the unit and see if it's user-friendly, okay? That's really important. Does the company provide good support? Another great question, right? Is there educational support? Is there support for your setup? What's the support like? All right. I want to talk to you for a few minutes before we go into the actual procedures. I want to talk to you about what compelled me to see the huge value of diode lasers. And I'm going to use this image here and ask you, when you see this image, what do you see? To the left of this image, or on the tooth structure, we see that supragingival, or the subgingival deposit, okay? And this is what's creating that localized infection, or the gingival response. So that's the bacterial aspect, and we know that many present with this, okay? But in contrast, this ulceration of the sulcular epithelium is the destruction caused by the inflammatory aspect of the disease, or the host response, okay? And it's this that's leading to periodontal breakdown and the destruction, as well as further systemic involvement for our patients. So our question would be, once we remove that hard deposit, what are we going to do about the ulceration? Okay, what do we have to help with that inflammatory aspect of the disease? And that's where it gets interesting, okay? With the American Academy of Periodontology redefining periodontal disease as an inflammatory disease, it's very important that we as the dental hygienists employ protocols that are going to address this component of the disease. And if we don't, if we ignore the inflammatory aspect of periodontal disease, we will inadvertently set up our patients for risk of further systemic disease. At the same time, our treatment outcomes will continue to be at a standstill if we continue to ignore the host response, right? I think that's the definition of insanity, right? Trying the same thing over and over again, but expecting a different result. The last thing I will say about the inflammatory process here is I like this image. So let's walk through this here. Essentially, the very moment any of these intruders, so virus, bacteria, maybe it's trauma, anytime one of these intruders enter a well-functioning system, our inflammatory or our immune system, I should say, reacts and essentially engulfs the foreign invader, right? So we have this natural period of tissue destruction, but it's equally paired by tissue repair. So the result is our healed tissue. The problem is, in the presence of an inflammatory disease like periodontitis, the problem isn't resolved. So when a transient infection becomes chronic, the very thing that would have performed well in a healthy body actually turns the body against itself. And one of the kind of key events that takes place here is the inflammatory marker MMP8, or if you remember back from your dental hygiene days, collagenase. And this is what breaks down collagen. So collagen is really found in abundance in the oral cavity. So we have, I would say 60% of our soft tissue is made up of collagen, and 90% of alveolar bone is collagen. So kind of a hot commodity in the oral cavity. And overproduction of collagenase is what leads to the periodontal breakdown. So chronic periodontitis is one of the most common chronic inflammatory diseases known to humankind. So that puts us, the dental hygienists, at the forefront with a really, really great opportunity, but also the responsibility to educate our clients on how they can help to control oral inflammation, okay? And this isn't all doom and gloom. I think this has taken a really kind of sharp turn from just the lighthearted Canadian humor that we had at the beginning. But it's okay, because the good news is that laser therapy has been shown to have an impact not only on the bacterial aspect of the disease, but also on the inflammatory markers and the host response. And when I had this explained to me, I got really excited and just felt, again, that personal conviction that laser therapy was the tool I wanted to implement. So the synergistic approach here of lasers in combination with traditional dental hygiene therapy is part of the solution, leading the way to improvement orally and systemically, okay? So that sets us up nicely to talk about, there's sort of 4 prominent procedures in dental hygiene. Now, I do have to preface this by saying, I'm not the ultimate authority as far as what you can do either in your state or your province, or even your country, wherever you're joining us from this evening. So I'm going to talk about the 4 main procedures, but please do check in with your state regulations or your regulatory body just to make sure that, first of all, lasers is in your scope and that the actual procedure we're talking about is also within your scope. So when I talk lasers, I've been known to talk for a long time. So I found a way to narrow this down. And the best way that I can think of to talk about these 4 procedures is to talk about the who, the why, when, and where for how they come into play. So the first one here we're going to talk about is LBR. So that acronym stands for laser bacterial reduction. And essentially what this is it's a pre-procedural decontamination tool that we're going to use to reduce the bacteria in the sulcus. And when I said earlier that it's the science and the physics that's kind of the hard part about lasers, but the procedure themselves, I mean, LBR, this is going to be one of the easiest skills you learn in your dental hygiene career, okay? And you know what? Manual dexterity is not something that is in short supply with this audience. It's very, very fast. It's about 5 minutes at the beginning of the procedure, and it's a painless procedure. Now, we're going to do LBR before we do our mechanical debridement. And there's a couple of reasons for that. It wouldn't be wrong to use LBR after we do our mechanical debridement, but the reason that I'm going to stress doing it before, wherever possible, is because when we do it before, we're helping to reduce the occurrence of bacteremia. The other thing it's doing is it's going to help reduce cross-contamination from one site to the next. The other impact of using LBR before we go in with our instruments is it's going to reduce the bacterial load, which is benefiting us and our patients because we're reducing the bacteria and aerosols that are going to be produced, right? So everybody's kept healthier by doing LBR before we do our mechanical debridement. Obviously, there are going to be exceptions. If you simply cannot get in, you know, that wall-to-wall calculus we sometimes find on the linguals of our mandibular anteriors, sometimes we'll have to do some light debridement before we can get in there, but wherever possible, before is what I'm going to suggest. So when it comes to who benefits from LBR, think about any client with inflammation. Any client with inflammation is going to benefit. Clients with bleeding. So if you have patients presenting with greater than 10% bleeding sites, they're going to benefit from LBR. Immunocompromised clients, right? Just helping them to keep their bacterial load controlled. Appointments where aerosol use is indicated. Our periodontal maintenance clients. So we're going to talk about a procedure that's going to be really helpful for our kind of advanced perio cases. But once we've got our perio patients to maybe a more stable state or maybe into remission, you know, one thing we know about periodontal patients is once a periodontal patient, always a periodontal patient. So we don't want to let our guard down. So our periodontal maintenance clients will benefit from LBR. And really, any presence of risk factors. So maybe they are a smoker, again, diabetes, even obesity can be a risk factor, right? Any risk factor that they may present with, we can use laser bacterial reduction to help them keep their bacterial load at bay. So I want to show you kind of what's happening at a microscopic level when it comes to laser bacterial reduction. So here we go. I have this very high-tech illustration. So pay attention. This is intense. We have our cell, and then we have the laser energy that comes in. The cell expands until it vaporizes, right? I warned you it was very intense. But this is what's happening, right? This is, you know, if we wanted to kind of break it down to the simple terms, this is what's happening. It's a photothermal reaction of absorption, and it produces a temperature rise in the targeted bacteria until it vaporizes. And that's what's happening with our LBR. All right, I'm going to move on to the next technique we're going to talk about, and that is laser desensitization. And this is arguably one of my favorite techniques. And this is why. I don't know if you would agree with me, but in dental hygiene, a lot of what we do is somewhat thankless, right? We are in it for the long term. You know, if you've ever been with a patient and they're going on an hour of, you know, scaling and root planing, and you're still kind of, you know, you're just in one quadrant and you're thinking, this is life-changing scaling and root planing that's taking place. And the patient looks up to you and says, are we about done here? Because I have a lunch date, right? How deflating. But, you know, it's not as instantly gratifying as when they come in and, you know, if they have a huge black hole and they leave with a beautiful white restoration, you know, it's not as instantly gratifying as getting a crown placed or some of these other things. We know that what's happening is very significant, but it's not always so visible. With desensitization, it's this instantly gratifying situation that I just find very exciting. So let me talk to you about why this is happening, what's happening, and why this is, to me, a superior method of desensitizing. Because there are many, you know, materials and products we can use for sensitivity, but this is among my favorite. There's a couple of theories as far as what's happening with desensitization. So the first theory is the hydrodynamic theory. which basically just suggests that the fluid within our tooth, so we've got our pulp, and then the fluid is moving towards and away from the pulp. And the more this fluid is moving, the more sensitivity is felt. When we use our diode laser, it actually changes this fluid viscosity and renders it a little more viscous. So it's moving a little less frequently, or it's moving more slowly. The less that it moves, the less sensitivity is felt. The other theory, usually when we do desensitization, we'll apply a fluoride varnish first. So the other theory is that the laser is simply driving the fluoride ions deeper and creating a more sophisticated chemical bond. And truthfully, I won't argue which one is the correct theory. I think they are both valid. I have achieved success with some of my sort of fluoride averse patients where I've used the laser exclusively and have seen some great results. But I do think that both hold merit. But what's significant here is that the results last from 6 months up to even about a year. And these patients are going to be happy. I will warn you, they may hug you. They may be so overcome with joy that they just can't help but hug you. I'll actually get them to, before I start, I'll say, okay, breathe in. So they'll go, and then they'll kind of point those areas that they feel that sensitivity. And then after I'm done using the laser, I'll say, okay, try that exercise again. And that's where that instant gratification comes in, where they'll feel that difference. And I find that very exciting. So the WHO for laser desensitizing would be clients with full mouth sensitivity, those clients who say, ouch, as soon as you place the mirror intraorally, clients with site-specific sensitivity. So again, it could be the full mouth or could be just site-specific. And that's the beautiful thing, is that you can just specifically select those sites. Clients with anxiety around dental treatment. The reason that I have that one in there is sometimes they come in and they're so anxious, they're white knuckled from the start of the appointment. And when you investigate that further, it's because they may have one site, just one site that is always, as soon as you touch it, they just hit the roof, but they're anticipating that one site the whole time. So if we could go in pre-procedurally and just treat that one site for them, I mean, I don't know about you, but when someone's really, really anxious in my chair, I'm anxious too, right? We care about our patients. We don't want to be hurting them. So this could be something that reduces their anxiety and reduces ours at the same time. All right. The third procedure we're going to talk about here is oral lesions. So the diode laser is very effective in treating minor, major, herpetiform, and recurrent herpes. It's also having an impact on treating the symptoms of lichen planus, denture sores, chemotherapy-induced mucositis, right? So these very, very sensitive lesions, we're helping our clients we're speeding up the healing, but we're also desensitizing the area. This is another one that's sort of immediately gratifying. Two situations that I can think of. One was a young lady who had her wedding photos in 10 days. And she came in and she said, oh, there's this herpetic lesion that comes, every year I get it in the same spot and I can feel it, it's coming out, and I have my pictures in 10 days. And she wasn't even telling me because she thought I had a solution. She was just kind of venting. And I said, oh, well, I have this diode laser that can really help. Would you like me to try it? And of course she said, I'll try anything. So I treated the lesion. It took me all of, 3 minutes. She went on her way. About a month later, a handwritten letter to the office, just expressing how happy she was, how thankful she was that the office would bring this technology in and that we would take the time to meet such a specific need that meant the world to her, right? And that becomes a patient for life. Second situation, and it's funny, I tell the story, and this was 10 years ago, right? I've had so many events happen in my 16, almost 17 years of dental hygiene experience. And yet this one story means more to me than I think anything. And it was this little boy who came in, and he was 5 years old, and his mom brought him in just to tell me that we couldn't proceed with treatment because he was in so much discomfort. I said, oh, I'm so sorry. Can you tell me what's going on? So he pulled down his lip and had little crocodile tears, and he was this massive aphthous ulcer. So his mom said, he hasn't eaten in 2 days. I mean, for myself, I don't think there's anything that would prevent me from eating for 2 days. But for him, that was all it took. It was very painful and he didn't want to eat. So I said, I'm so sorry. Of course, we don't need to do your hygiene therapy today. But I have this magic pen. Could I give it a try? And of course, I explained to the mother in more technical terms, and she agreed. And again, it took me 3 minutes. And I said, okay, can you feel around with your tongue? And you could tell how nervous he was to even feel it with his tongue because it had been so painful. So he's looking around. He looks at me kind of confused. And he goes, it's gone. You're magic. Of course, I wasn't going to disagree. And so no word of a lie, I did one of these, backed out of the room like this, laser girl, right? I had to come back in the room because of the whole process of care. But, for a moment, it was this epic situation. And, all jokes aside, this became a patient for life, right? They were, again, writing Google reviews, telling the office how happy they were, telling their friends, right? It's changing the way people are talking about dentistry, right? It's influencing the conversations that are taking place. So for that reason, this is, again, one of my favorite uses of the laser. So in a scientific level, what's happening here is the laser energy is penetrating into the lesion and being absorbed by the lesion. The lesion is going to be less likely to reappear in the same location. The healing time is faster, and the discomfort is alleviated almost immediately, right? So that's what happened with the herpetic lesion. We sped up the healing time. That annoying kind of tingling sensation was also taken away. But for her, more importantly, it was the fact that the lesion wasn't there. And for the little boy, the lesion was still there, but we had immediately desensitized it. Now, it is best to treat these lesions in the first 48 hours and not in the healing stage. Again, I have heard different things on this. Myself, the reason I don't want to treat a lesion or a herpetic lesion, I should say, in the healing stage is once it's kind of weeping, I don't want to aerosolize that viral load. So for me, the best success I have seen and sort of the safest in my mind is in that kind of prodromal stage. So the first 48 hours or so. So this one's probably a more obvious who. So this is going to be clients who present with early stage herpetic lesions, clients who have painful aphthous ulcers, clients with painful lesions within the vermilion border. And again, it depends on your region, what you're allowed to actually treat and where you're allowed to treat it. You may get some awkward requests from friends and family once you tell them that you've been laser certified. So the way I get out of those awkward situations is I say, oh, can't be past the vermilion border. Okay, the final technique I want to talk about here is LAPT. So that acronym stands for laser assisted periodontal therapy. So this one is maybe a bit more of a broad term. Some will refer to this as laser curettage, and myself, I refer to it as periodebridement. I feel like that terminology is just a little more kind of all-encompassing of what's taking place. So with our laser assisted periodontal therapy, it's a little bit different than our LBR. We're actually taking our fiber and we're going to the base of the pocket and we're covering the entire pocket wall. What this is doing is it's targeting the embedded bacteria and their endotoxins beyond our reach. Subsequently, we'll see the removal of the diseased epithelial wall of the periodontal pocket. What this is going to do is it's going to help us achieve hemostasis and promote tissue healing. Because we're covering the whole pocket wall, this procedure is not quite as quick as our LBR was. The actual amount of time that you're going to spend in each pocket does depend on the severity of the disease. It really is patient specific, but it's definitely not going to be that kind of quick 5-minute procedure that LBR would be. Another thing that's happening here is it's actually going to give us greater visibility because it's going to decrease the bleeding, and it's also going to decrease the inflammation or that fluid retention. So you'll see the really edematous tissue actually kind of come back down. We're going to see subsequent coagulation of blood vesicles. And we're also finding there's this protein denaturing. And I want to be very transparent when I'm talking about something that is sort of the research is ongoing. So what I'm about to say is more from conversations between laser users. And what we're finding is when we do LAPT before our mechanical debridement, because this procedure can be done before or after, again, depending on your province or state, or depending on your patient. But when this procedure is done first, it almost seems like the calculus is becoming a little more crumbly in consistency. And again, I don't have the research to back that up, and I need to be transparent about that. But the thought process is that it's denaturing the protein, or even targeting that lipopolysaccharide chain of biofilm, making it easier to remove. So that science is ongoing. The studies do support a delayed recolonization period. So we're bringing the bacterial load down and delaying the recolonization. The goal here is tissue rehabilitation. Now I want to show this image. This is before and after LAPT. So you can see this isn't 3 weeks later, this is immediately after. Okay, so before LAPT, immediately after, and you can see the tissue tone changing. So we're going to use this for a periodontitis diagnosis, okay? Or maybe our unresponsive cases where we've tried different modalities, nothing seems to be giving us that success. Cases of gingival hyperplasia or edematous tissue, maybe site-specific areas after our initial treatment, or our highly sensitive clients. It does tend to have a bit of a desensitizing effect on the tissues. All right. Is there much research to support the use in dental hygiene? Yes, there is. And I'm going to share a little bit about it. So this first study here has nothing to do with lasers. The reason that I have it here is because it was a study done to sort of elevate the awareness of the occurrence of bacteremia. So after scaling and root planing, they took blood samples, and what they found was in the bloodstream, P. intermedia, AA, P. gingivalis, and B. forsythus. So unfortunately, the occurrence of bacteremia happens and occurs more than we would like it to. And this leads me to my first actual laser study, which is they studied a group of individuals who had just ultrasonics used, and then another group who had diode lasers and ultrasonics used. And they found 68% of those who just had ultrasonics showed the occurrence of bacteremia, compared to only 36% of those who had the combination of diode lasers and ultrasonics. When it comes to periodontal disease, not all bacteria are created equal. And the next study that I'm going to show, the reason that I'm showing it is because it specifically talks about 2 bacteria, one being AA, which is a very aggressive bacteria that's really difficult for us to remove with mechanical debridement alone. So it tends to adhere to diseased root surfaces and is really difficult to remove. The second one, which is perhaps the bacterial felon of my nightmares, is P. gingivalis. This one is a keystone pathogen involved in the advancement of periodontitis by boosting the virulence of the entire bacterial colony, rendering them all more destructive, right? So they're communicating to each other. They'll actually hide out in a cell when they're under attack, send other bacteria to die off while they hide, only to emerge when it's safe. Okay, so highly intelligent bacteria that are capable of communicating with each other. That's what we're dealing with here. And again, one that's very, very difficult to remove. So I love this study because it was specifically looking at the elimination of these 2 bacteria. So the results here, they tested a group again with just mechanical debridement, another group with diode lasers and mechanical debridement. And after microbiological samples, they found a statistically significant decrease in the targeted pathogens being AA and P. gingivalis. So I got really excited when I saw that. Okay, the last study that I want to show here, and the reason I'm showing it, when we were talking about that overproduction of collagenase being a key event with inflammatory diseases, when they were doing a similar study that we just talked about, this time what they found was that the diode laser provided significant improvements in clinical parameters, and MMP8 was significantly impacted by the adjunctive laser treatment at first month, providing an insight on how lasers can enhance the outcome of non-surgical periotherapy. So I saw that and I got really excited. Okay, So that is the research. I do encourage you to look into the research for yourself, just again, so that it's not just a presenter telling you, but you're actually feeling that personal conviction. All right, I want to close the evening by talking a little bit again. Like I say, this isn't the part that gets my heart pumping, but it's important that we talk about it. And that is the ROI for laser use. And so if this can help, I am going to use Canadian terms here. So I will provide you with an email address in a moment if you're looking for codes or billing procedures for the US. Lynn Atkinson has very graciously given me her email address to help you out. So I'm just going to take a moment and kind of speak Canadian for a second here. This was a trial. RDHU partnered up with Waterlase to do a trial in Ottawa. So we certified an office and then we followed them for about 2.5 weeks. And at the time in Ontario, we were only doing LVR, desensitization, and oral lesions. So it wasn't until later that we incorporated the LAPT. Nevertheless, in these 2.5 weeks, they did 28 LVR procedures, 18 desensitization, and 4 oral lesions, making that about 3,000 for 2.5 weeks. And that was 2 operatories, so not a huge practice. When we added in LAPT, okay, and then averaged that out for the year, the yearly revenue was 64,980. Okay, so very easy. When you add in the cost or you subtract the cost of the diode lasers, which are a very reasonable cost, you're still left with a significant value add to the practice. Okay, so what gets me excited is what we just talked about, right? The impact on the oral health and the systemic health of our patients. But this is definitely worth mentioning. And if this can help you get a laser into your practice, then please, please use this. Again, Canadian codes, Canadian dollars. But if you're looking for more specifics for the US, then I'd highly encourage you to reach out to Lynn Atkinson, who's just a wealth of knowledge. And again, she graciously allowed me to put her email address on there for you. All right. So if you have become excited and you want to take that next step in your laser career and you want to get certified, you might be asking, how do I become authorized to use lasers? Again, if you're here from the US and you want more information, I'd encourage you to reach out to Waterlase or even Lynn Atkinson, I'm sure can help you. But if you're joining me from Canada, I'm your girl. I can help you out with that. So go ahead and scan this QR code for upcoming laser courses in your area. And I can help you out with that. I just, again, want to thank you all so much for just spending this time with me. What I'm going to do is I'm going to leave my email address up there just for a moment. We're going to take some questions, but before we do, I just want to show you just very, very quickly. I have a camera here. I just want to show you the difference between LVR and LAPT. Sometimes I think the visual really helps to bring everything together. So I'm going to stop sharing my screen for a moment here and switch over my camera. And then we'll take up some questions. Okay. Just give me a moment. Here we go. All right.
Looks great.
So you got it there? Thank you, Nathan. So with our LVR, as I was saying, it's so easy. You're just going to take your laser filament and it's just going in about 0.5 millimeter. Okay, so it's just barely going into the sulcus there, 0.5 millimeter. And really all you're doing is just pulling it along. That's it. That's LVR. Sometimes I'll kind of go up and down here when I'm interproximal, just where the tissue is a little bit thicker. And you'll even see some presenters who do sort of more of a sweeping motion, but really, and again, I won't argue here or there with that. The point is that we're allowing that energy to be absorbed. Okay, so 0.5 millimeter into the sulcus and pulling it across. All right. With our LAPT, slightly different. We're going to go right down to the base of the pocket, minus about 1 millimeter. And with this technique, we're actually going to be almost like we're painting the wall. So more of a cross-hatching motion here. I like to work in channels. I'll come up, I'll sort of wipe off the tip if there's any material on there, and then I'll reinsert. And I like to work in channels. Again, you'll notice some very slight variations in technique from clinician to clinician, but that's the general idea. where we're slightly directing it to the soft tissue wall and painting, almost like we're painting the wall. Coming back out, wiping off any of that material that's there. All right, so this is something, again, you'll go into detail when you take a certification course. That'll give you sort of a general idea of how it actually looks in practice. All right, how are we doing for questions?
Well, that was a wonderful demonstration, Beth. I think you're the first one actually to have a camera like that set up on one of these webinars. So really, really appreciate that. We're good on time. We have at least 10 minutes here. We don't have too many questions, so everybody, please get your questions in using the Q&A toolbar at the bottom of your Zoom screen. It's not the chat button, but the one that says Q&A. Do have a few though.
Okay.
Let's see here. Maggie Lanza asks, you might have gone over this, sorry. How do you use the laser for desensitizing? I only use it for LBR and cold sores.
Oh, that's a really good question. And you know what I'll do? I'm just going to switch back over here for a second. Just give me a minute. It's best if I just show you. Good question. So it's very, very easy. Again, what I'm going to suggest is that you apply a fluoride varnish first. Okay. And then what you're doing is you're actually I like to do a circle motion. It just seems a little more natural to me. Again, some people will do like a crosshatch, but I'll actually just do circular motions. I'm about 3 millimeters away from the tooth. And I'm just going to I'm almost painting little circles. And you're going to be here for up to about 60 seconds per site. No need to go on the occlusal or the lingual, because again, with that hydrodynamic theory, we just want to alter that fluid viscosity or drive the fluoride ions deeper. And that is desensitization.
Wonderful, thank you. Sala Scala asks, do you use an active or inactive tip for LAPT? And could you please go over active or inactive, or sometimes known as initiated or non-initiated?
For sure. So with, again, this is going to depend on your state regulation or your province regulatory body. With our laser bacterial reduction, one way to look at it is you're basically taking your tip right out of the sterilized package, you are putting it in and you're using it directly. Okay, we haven't done anything to our tip. On the contrary, with LAPT, because we want to, again, we're removing sort of the endotoxins and that dead epithelial lining. If your state or province allows it, you can initiate your tip. Because the laser is going to be, the wavelength is attracted to pigment, you can use something like articulating paper, and you just have to touch it and you'll see it kind of smoke, like you'll see it almost kind of fire off. Just have to touch it. And now what happens is with an uninitiated tip, without us kind of using the articulating paper, the energy is just allowed to flow into the pocket. When we use something like this to sort of fire off or initiate our tip, we've now made it a more concentrated source of energy. Okay, so the energy is going to be concentrated on the tip, which is why it's going to interact more when it's approaching that diseased tissue. Now, again, it's not attracted to healthy tissue. So as long as we have the right settings in place, which is where the safety and the training comes into play, as long as those subsurgical settings are in place, we're just going to be removing dead epithelial lining and not healthy tissue. So with LAPT, this is probably a very long-winded answer, but with LAPT, you can initiate the tip. If you are somewhere where you can't initiate the tip, you could also use the LAPT procedure. However, sometimes because it's attracted to that kind of pigment, it may initiate itself once you're in the pocket, but technically you wouldn't be initiating it. You can go in there to do LAPT without initiating it. And your manufacturer's instructions for your unit will actually give you instructions on that part, but hopefully that shows the difference between the two.
Thank you, Beth. And I'd also like to point out to always check with your local state government board rules, etc. for those.
Yes.
On a similar note, Chelsea Jarrett is asking if you could go over diode settings for LBR versus LAPT. And along with that, as a part two, is there a certain motion or direction for LAPT so the heat doesn't bother patients?
Right. So great questions. I think what I'll use right now, because diodes are all created a little bit differently. So you might have an 810 nanometer laser, or in the Biolase family, you have a 940 nanometer or a 980 nanometer laser. And the actual presets themselves, lucky for us, there is a physicist behind those settings. So those settings are there for a reason. Use that as your starting point. But again, it is just a guideline. You always want to be looking at your patient and kind of watching that tissue interaction and adjust accordingly. If you're performing LAPT and you see any kind of charring or smoking, then you want to adjust those settings, because that's not what we're after. With LAPT, so let me use the Epic. I'm going to use the Epic H as the base, just to give you an example. So with our Epic H, we're going to be using about 0.8 watts, and we're going to be using a duty cycle of 50%. So that means it's a chopped pulse that we're using. And for the most part, again, completely depending on your state regulation, you're going to be using an initiated tip or not initiating it, depending on what you're allowed to do and where you reside. With our pocket therapy, so our LBR, we're going to be using something slightly lower. So we're 0.5 watts and we're a 10% duty cycle. So a slightly lower setting. And for laser bacterial reduction, it's all about absorption. We just want that wavelength, that diode laser energy to be flowing into the pocket. So we don't want to use an initiated tip at all with our laser bacterial reduction, because we want the laser energy just simply flow. Okay, so lower setting, uninitiated tip with our laser bacterial reduction.
Thank you so much, Beth. Is there a certain motion that you use for LAPT?
For LAPT, I use kind of this cross-hatching motion. So I have seen some that do almost like a J stroke, where they insert the tip and they're kind of going like a J as they go across. What I have personally found to be the most successful is I go into the base of the pocket, minus that 1 millimeter. I turn the laser filament slightly towards the tissue, and I do like a crosshatch motion, right? Again, the reason I'm doing a crosshatch motion is I want to make sure that the entire wall has been covered with my laser.
Got it. Martin Oseda is asking if the diameter of the tip is important in this kind of therapy.
Yes, that is such a good question. So I get excited about physics. I love physics. If you think about, okay, let's use a hose as an example. If you're in a water fight, you know how you have those hoses that you can adjust the nozzle? If you have someone who's standing right beside you and you want to drench them with water, you're going to use the fattest hole, right? And the water's just going to pour out. But if that person starts running and you want to get them, you have that same kind of force coming through, but you're going to use a smaller tip, because now you have all this force coming through a small tip. That water is going to go shooting across with more power. So the same thing is true with our tips. If we're using a really wide diameter tip, then the laser energy is covering a greater surface area, which, for lack of a better term, almost gives you sort of like a weaker beam. Whereas if you use a smaller diameter, now you have the same wavelength or the same power coming through, but at a very small surface size. So that's going to be a more powerful beam. So it is important, and the presets of your units have been catered to the type of tip. So you'll notice on your manufacturer's instructions, it'll say something like E4, which means a 400 micron, versus something like a 3, which would be like a 3 or 320. So very, very important. And definitely with that, it's not just a universal answer across the board. Do follow the manufacturer's instructions for your unit.
Thank you so much, Beth. It's really nice having so many questions and having this back and forth. It's actually quite rare for us to have so many. So thank you very much for your time on answering these.
Of course. No, it's my pleasure.
We do have a question regarding LBR here. Maggie Lanza asks, do you recommend sub-irrigating with LBR?
I get that question a lot, and I don't want to, again, I don't want to claim to have all the answers. I'll give you my rationale, and then again, you get to make your own kind of clinical judgment here. One really amazing thing about lasers, and that some studies have found, is that LBR has a proliferation effect on fibroblast formation. One of the, it was RDH magazine, I think 2015, came out with an article talking about how chlorhexidine specifically actually has an inhibitory effect. So my question would be, would irrigating with something like chlorhexidine give any added benefit? And that's, for myself, I just don't think it gives me anything more than what my laser would be doing. And in fact, I wonder if it actually combats that fibroblast ligament proliferation effect of LBR. So that's more of a clinical question, but that's where I'm coming from when I say no.
Thanks, Beth. I think we have time for one final question. Amy Burke here is asking about aphthous ulcers, and if you could show a quick demo, perhaps with your
yes,
laser.
I would love to. Okay, let me just grab my camera, switch over here. Okay, so let's pretend that this little knob here is the lesion. So I like to, and again, you're going to find that different instructors have just slight, there's going to always be a very slight difference. And again, it's not that one person is wrong, one person's right. It's just, let's embrace all of the different ways we learn about it, and then we get to make our clinical judgment. I like to start sort of defocused and gradually become more focused. So I will do 3 passes. All right. So the range that I use is from about 0.6 watts up to about 0.8 watts. I'll start my first pass about 10 millimeters away from the lesion. Okay. And I'm going to start at the lowest setting. And I'm going to be just slightly outside of that lesion. And I like to do circles. Some will do a cross-hatching motion. I like circles because it's just more natural for me. But the point is that you're covering the entire lesion. I'm going to stop. I'm going to let that tissue rest for about 30 seconds. If the patient isn't experiencing anything more than just a gentle warmth, I'll increase it by 1. I'll move from 0.6 up to 0.7. And now I move a little closer. So now I'm 7 millimeters away, but I'm going to do the exact same procedure. I like to do circles, painting the whole lesion. I stop for about 30 seconds, make sure the patient's okay. If they are, I increase it 1 final time. And this last pass, I'm only about 3 millimeters away. But the same thing, I'm starting a little bit outside of the lesion and just sort of gradually, almost like a bullseye, coming in, going back out, making sure the entire lesion has been covered. Each pass is about 30 seconds, I would say, and that's it. That's a lesion. So fast, but a huge impact on our patients.
And Dr. Victoria is asking what is the tip that you're using? Do you have a favorite tip?
I like to use, so again, it's actually the manufacturers suggest the E4 tip, which is a 400 micron. You can get them in different lengths, so depending on the procedure that you're doing, but I would say it's a 400 as far as the diameter is concerned. And I love these ones. They're just tiny little guys. You just screw in and screw out when you're done. Single use, very easy.
Well, thank you so much, Beth, and really, really appreciate all the extra time for going on through those questions.